Yeah, thank you for the introduction, Miera. Dear colleagues, the only approved device for long-term mechanical support in children is the XCO device from Berlin Heart, and according to the company's registry covering more than 1,500 implantations, the main indication for implantation of a XCO device is dilated cardiomyopathy, followed by about a quarter of patients with congenital heart disease, and the next large group as the myocarditis group was 11%. While recovery from severe heart failure in myocarditis is well described, the incidence in dilated cardiomyopathy is even less well described. The group of congenital heart diseases is a very heterogeneous group covering diagnoses like acquired or congenital coronary disease or failing single ventricle patients. And it is not surprising that recovery rates in congenital heart disease are highly variable. So it is obvious that the probability of myocardial recovery in children on ventricular assist devices depends highly on the diagnosis. So let me start with myocarditis. At the beginning of the disease, the virus enters into the myocytes and replicates in the cell, leading to myocyte injury, leading to necrosis of the cell and exposure of intracellular antigens to the circulation, and that will activate the host's immune system, which is characterized by the invasion of NK cells and T lymphocytes. And this acute phase only takes a few days. After the acute phase of virus-induced myocardial injury, the second phase is characterized by immune reactions. In this phase, which covers few weeks or several months, it is characterized by activated T lymphocytes, which may target the host's organs by molecular mimicry. So, as a consequence, the cytokine activation occurs, and antibodies to viral and cardiac proteins may aggravate the myocardial injury. In most patients with myocarditis, the immune response declines with virus elimination, and left ventricular function normalizes. However, there is a percentage of patients where the immune process persists, and these patients develop dilated and chronic cardiomyopathy. For us, it is not possible to predict which patients recovers completely and which patients will suffer from dilated cardiomyopathy. And there's growing evidence that genetic factors play a role in this disease process, as we know that certain genetic mutations predispose patients for acute myocarditis, and as well a predisposing factor for dilated cardiomyopathy. So I think that we have an overlap in the diseases between myocarditis, genetics variants, or even mutations, and chronic dilated cardiomyopathy. What are the outcomes of pediatric myocarditis and dilated cardiomyopathy? In this large US registry, the outcomes are depicted depending on the diagnosis. Interestingly, they found out that patients with biopsy-proven myocarditis have exactly the same outcome as patients with biopsy-negative disease, which were clinically diagnosed as having an acute myocarditis. What's the difference? And these patients are all combined in the left picture here that is biopsy proven as well as biopsy negative clinically myocarditis. But what's the difference is if the patient presents with a dilated left ventricle at diagnosis. And as you can see there, the rate of echocardiographic normalization differs significantly between these two groups, as well as the rate of transplantation, which becomes necessary over the years. The rate of fatality was not different, but what we know is that patients with more severely impaired left ventricular function have worse prognosis and will have higher fatality rates. Finally, the data reveal that even in idiopathic dilated cardiomyopathy, there is a certain percentage of patients who will normalize in their echocardiographic function. So when we are talking about recovery due to mechanical support, we have to keep in mind that there is a natural course, that there is a percentage of patients they will recover even if we do a banding, do a medication, or use a ventricular assist device. And it's very difficult to differentiate which method leads to which outcome. So what is the role of mechanical support in myocardial recovery in children? And to start first with the myocarditis group, it is clear that in patients with severely depressed myocardial function in Intermax stadium 1 or even 2, they need mechanical support, and traditionally that is applied with ECMO or extracorporeal life support, ECLS. This is data from the ELSA registry showing that about 60% of children on ECMO will recover with the diagnosis of myocarditis, and on the other hand, there is a high percentage of patients who dies, as well, 40%, and only a very small percentage which can bridge the transplantation with ECMO. So the question is, if the VAD support can induce or at least facilitate reverse remodeling in dilated cardiomyopathy, and reverse remodeling means a reversal of an alteration of myocardial structure. So complete recovery on VAD support would include changes at a cellular, molecular, and genomic levels, which occur with a relatively high probability, but must lead to a change in anatomy and function of the heart, which is less frequent, and eventually have to lead to clinical improvement allowing for VAD removal, and that occurs with a really lower probability, and the number here given by Daniel with less than 20%. In the international registries, it's below 10%, I think. So there is some evidence, even in children, proving that changes at the cellular and histologic level can be observed after VAD implantation. In this study from Carsten and co-workers, they did myocardial biopsy pre-LVAD implantation and post-LVAD explantation during transplantation. So all patients, that are 17 patients in the study, received a heart transplantation except the one who died. And what they could show in comparing the pre- and post-LVAD specimen is that there is a proliferation of myocytes shown in red, and that is statistically significant, and that they could show that at least in the smaller age group, less than 5 years, there's a significant drop in fibrosis in the hearts. There are several publications in the international literature describing recovery after VAD support, and this is an overview over these publications, and with the exception of these two studies, the number is about 5 to 10%. There is one group here from Zimmerman that is the same, that in part the patient population is overlapping here. This patient is more or less a myocarditis population, therefore there is this high recovery rate. And then the first publication from the Herzzentrum by Hetzer in 2006 showed that there is a recovery rate of about 20%. So the international picture actually is that recovery rates only now on EXCO patients in myocarditis is about 20%, in cardiomyopathy 3.5%, and post-cardiotomy 15%. This is data from the Berlin Heart Registry. That means that that data is not very granular, and it's not possible for us to get more information about the patients. So the Herzzentrum has a relatively long history of weaning experience, and that was pioneered by the adult group, was Professor Dandel, and he developed some echocardiographic criteria on off-pump trials to evaluate if a heart on mechanical support might have been recovered. And that is the criteria he proposed in his study from 2011. And what he could show very nicely is that if these criteria are not met, the risk of recurrence of heart failure is very high. So in the more recent years, they stick to the criteria and had better results. And that motivated us to prospectively develop a protocol adapted for children. And our strategy is to transfer these values into children, adaptable for children. So it is not the 5.5 centimeters LVEADD. So we say the Z-score must be less than +2 and so on. So this protocol is in place more or less in 2010, and in the following slides I will show you our experience with our protocol. If we put a patient on an EXCO device and it has recovered from implantation, we will start chronic heart failure therapy and look very twice a week or once a week for signs of ventricular recovery with the echocardiographic examination. And if the ventricles are of normal size and we see that the heart is pumping very well, we would proceed to a short pump stop echo on the ward, on the normal ward, without sedation of the child. We will give him a bolus of heparin and stop the pump for 5 minutes, about 5. In practice, it is more 10 minutes, and evaluate the heart. And if the ejection fraction is better than 45%, the ventricle not too smaller than Z-score of 2, and there is no mitral regurgitation, we will decide to go to the cath lab to do a more prolonged stoppage of the pump with transthoracic echocardiography and right heart catheterization with invasive measurements. So, as today we have 30 children explanted, with a median age of 0.7. The oldest child was an adolescent of 16 years, and we have a median support time of only 63 days with a range of 6 to 140 days. And as you can see, we have a mixture of diagnoses. There is the largest group, is the myocarditis group, with 12 patients. We have 10 with the diagnosis of dilated cardiomyopathy and 8 patients with congenital heart disease. There are, I think, 5 patients with coronary problems, 2 with post-operative problems, and 3 with Alcapra. And interestingly, the support times. If you can compare the myocarditis group with the dilated group, there's a significant difference in support times, which means that there must be a difference in diagnosis between these two groups. So looking at our recovery rates in children, I decided to look at the children from 2000 ongoing, because I think in the first 10 years we have many improvements made in our protocol and had a learning curve. So I think it's better to look at the more recent patient. And it is 20 years with 135 patients. And in total, we have a recovery rate of 19.4%. And that is more than double the number of the PDMAX registry and the Euromax registry. And you may wonder why that is. And there is a subgroup in the PDMAX with paracorporal continuous flow pumps, the Levitronics pump, that is typically used in the US for the myocarditis group. And there's a recovery rate of 23%. However, in EXCO patients, the recovery rate is less than 1%. So in regard to diagnosis, our recovery rate in myocarditis is nearly 70%, which is better than that with ECLS. In dilated cardiomyopathy, it is about 10%. And interestingly, if you look at the size of patients, this patient group less than 5 kilograms is sometimes avoided to get implantations of EADs because of the inferior prognosis, had the best prognosis in regard to explantation of the device. We looked at positive predictors. Yevgeny referred to that in his talk. The one we found was age. It is significantly better to be young. This is the total cohort of 149 patients, and that is the days on VAD, and comparing the older with the younger patients, we have a significant higher numbers of recovery, and the same is true for the myocarditis group. It's highly significant. That's not too surprising. So what was missing in the literature is the long-term follow-up. Everybody is reporting that they are explanting the devices, but what happens the second and the third day, and what happens the second and the third year of the explantation? There's really no literature about this, and that is one of the reasons why we started to look at our patients, and I would like to present you this data as well. So we have a median follow-up of 6 years. I now include this is a bit different from our publication. I include all the patients who are recovered. In the publication, we only include patients who are off the device for more than 1 year. So we say successful recovery is only successful. It is possible to have no transplantation and no recurrence of heart failure for longer than 1 year. So these are all patients. The longest follow-up is over 20 years. And we have a mortality rate of 13% of patients who get their device explanted. There is 20% of patients had heart transplantation or a reimplantation of the rod or died. That is, in number, that is 4 patients died and 2 had a new had a transplantation or a revert. The numbers regarding diagnosis, there's no difference. That is a Kaplan-Meier curve for long-term outcome after explantation of the device, with a 10-year survival of about 90%, and 15 years the same, and that compares very well to the survival of children after heart transplantation. Please remember that in this curve there is 1 patient who is transplanted and 1 patient who is again on VAD. So the survival seems to be superior to the survival on after transplantation. And I think it's not only survival, it is also quality of life, and that is substantially different in children after transplantation compared to children after explantation of a device. So a short look at ejection fraction and diastolic diameter, that is the diameter, the ejection fraction, before implantation, that is a box plot with 18% EF at implantation. That is during pump stop. I think that's very interesting that you can see, you can more or less predict the ejection fraction during pump stop, how it would be at discharge. There's a small drop that is not significant between these two time points after the operation, but you can expect that the ejection fraction and as well the end diastolic diameter of the left ventricle is more or less stable over long-term follow-up. And the same is true for the pro-BNP. You see that is a BNP that is nearly 100-fold of upper normal for age. It drops at during assist device support. It comes up again after explantation, and then it drops again in long-term follow-up. However, you don't have to forget that many of the children, at least the dilated group, had a chronic disease. They are not completely normal, and they are still on chronic heart failure therapy with beta blocker, ACE inhibition, and so on. But the functional class is very good in these patients. So I have to summarize and conclude that recovery of ventricular function and VAD explantation is possible in the majority of children with myocarditis and in subgroups presenting with dilated cardiomyopathy. The survival, functional class, and quality of life after explantation is really excellent. I think it's really superior to transplantation, with a remarkable stable cardiac function. 2/3 of children needed chronic heart failure treatment at long-term follow-up, and I believe that a standardized approach may help to increase explantation rates in children supported with a VAD. Thank you.